Hello, my name is Sandy Cho. I work at Newton Wellesley Hospital, and I'm honored for the opportunity to introduce my colleagues who will be our last speakers. Jennie Wright is a nurse with over 30 years of extensive experience in both the inpatient and ambulatory settings. Jennie has a focus and commitment to care coordination. She is currently the program director for population health at the Newton Wellesley Physician Hospital Organization, which encompasses outpatient care management, behavioral health, and work in the post-acute settings. Jennie's interests include fostering early communication regarding end-of-life care and promoting effective communication across the healthcare continuum. And Alanna Sieck, she currently works in a dual role at Newton Wellesley Hospital Physician Organization as the behavioral health team lead and a practicing social worker for the Integrated Care Management Program, providing consultation and support to primary care providers for their high-risk patients. Ms. Sieck is trained in cognitive behavioral therapy and other evidence-based approaches for treating substance use and co-occurring mental health disorders. She has spent over 11 years working on this field and received her master's degree from Smith College School for Social Work in 2011.
Well, thank you, everybody. Can you hear us or hear me? So I have to say, I've never been to an informatics conference before, and you guys are really fun. So much more fun than case management. So I would say I just wanted to give you a little bit for folks that aren't familiar with Newton Wellesley Hospital. We are a 265-bed teaching hospital affiliated with Partners Healthcare. Mass General, the Brigham, the Faulkner, and North Shore are our sisters. We are part of an initiative under Partners, which is called Population Health Management. And I have a little umbrella speech, so I'll do it really quickly. Probably around in 2011, Partners Healthcare started to recognize that care was going to move potentially from the inpatient setting across the continuum into the outpatient and post-acute setting. And with that in mind, they created what I like to refer to as a brain trust, Population Health Management. And population health management is really the outward-facing ambulatory kind of vision for Partners. And we have 3 initiatives under that, which include care management, behavioral health, and a post-acute initiative. One of the things that I thought was really interesting listening to your literature review today, because what could informatics have to do with ambulatory care management, and behavioral health? So let me tell you. Number 1, you guys mentioned population health management of populations across the continuum. 2, I heard the words care coordination referenced. 3, new technology seems to be on your radar as it is in ours. And then really team-based care. So when I think of team-based care, I think you'll find this presentation highly relevant because it really is expanding using technology who's on your healthcare team and how do we help providers think about other resources they can access. So I'm supposed to move this thing. Without even listening to the presentation, I think the idea of intention to use is an adept reference to these slides. So when Sandy talked to Alanna and I, one of the things we were thinking about, besides why would you want us to talk to you today, was what's the intersection between technology and clinical care? And I will say I'm first and foremost a clinician, and I tend to be a technology person that does only what I need to do to get that outcome. I don't want to learn how to do it 3 ways. I just want to learn how to do it once. So I think right now, and we have gone live in Epic, there's a lot of changes in technology. So there's a pervasive skepticism in many of our clinicians, just not nurses. I mean, nurses, care managers, doctors, NPs, people are really, I would say, fatigued out. There's a lot of technology adoption that we have to do very rapidly. So I think that it's fair to say that there's a pervasive skepticism. We're worried, is this going to take more time away from our patients? Are we going to make things more complicated? Are we going to take away that face-to-face component of clinical care that we all really value. And then I think the other one, certainly, I feel in the ambulatory setting, is there a poor return for investment on time? So if you're a physician and you're getting paid on a basis of how many patients you can see within a particular time frame, if I'm asking you to break for an hour, I have to have a really good reason why. So our experience with innovative technology, I think, in this particular example, has been very successful. I'm going to turn this over to Alanna.
Great, thanks, Jenny. So I think the big question today we wanted to share with everyone is what exactly is Project ECHO? So ECHO is a hub and spoke model that works to virtually share knowledge across large networks. It actually originated in New Mexico from a famous doctor. His name is Dr. Anjeev Arora, and he's a hepatitis C doctor. He realized that he had unbelievably long wait times for patients to come and see him. He had patients that were driving 2 or 3 hours from the New Mexico community to come and receive hepatitis C treatment in his clinic. So he hypothesized if he would be able to educate other providers, primarily primary care providers, they could educate and treat the same patients, touching more patients and having much higher and better healthcare outcomes for the New Mexico community. So I'm going to show a quick clip in the spirit of Friday afternoon that I think will show and demonstrate what Project ECHO looks like in 1 minute and 16 seconds.
Project ECHO is a performance optimizer. Think of it as a high-speed internet connection for the healthcare system. It spreads new medical knowledge throughout the healthcare system, from university medical centers and other specialty care sites to the front lines of community care. Rather than information flowing in one direction, community providers learn from specialists. They learn from each other, and specialists learn from community providers as new best practices emerge. Under ECHO, community providers use video technology to participate in guided practice with specialist mentors. They acquire new skills that allow them to treat patients they otherwise would have referred out. Patients with complex chronic conditions get high-quality care where they live from providers they know. No waiting months to see a specialist. No long drives back and forth to get critical care. ECHO exponentially increases access to specialty care by moving knowledge instead of moving patients. Suffering and pain are reduced, and lives are improved and even saved. Project ECHO, changing the world fast. Join us at echo.unm.edu. Are you part of the ECHO?
Great, so that kind of idealizes ECHO real quickly. So we're going to talk a little bit about the operation so you guys can get an idea of what it actually looks like. So just of note, ECHO is used broadly throughout the whole country and actually throughout the whole world. It doesn't address just healthcare outcomes, it addresses educational needs and Department of Defense. So in New Mexico, they started it with hepatitis C, but for Newton Wellesley, we had a focus on substance use disorders and really supporting our primary care practices and learning how to treat their patients. So Jennie and I talk about ECHO quite frequently, and we use this picture as an analogy for what it really looks like. And I think the Brady Bunch opening credits does some justice. But in reality, it looks like a hub and spoke as it's explained. So in the center, you have your hub, which are your content experts. This is actually a picture of the ECHO in New Mexico, which typically is comprised of a doctor, a nurse, a social worker, a pharmacist, all within this particular clinic have expertise in Hep C. Then surrounding them are all of their spokes. So these are referred to learners, perhaps primary care providers that would like to present a complicated case and receive advice and recommendations from that core hub that have content experts. However, we've found that those learners on the spoke are just as important and valuable as our core team because they have similar patient and profile and information that they can share, and it creates this really great multi-directional learning experience. So we're going to tell you a little bit about what this looked like at Newton Wellesley when we entered into our startup phase. So I actually had the opportunity to go to New Mexico and receive the training. And a quick plug for Project Echo is the training is completely free. They're really committed to sharing this education to clinicians that are interested. So it was a great way to grasp the concepts and really understand how we could launch this and implement it at Newton Wellesley. So first and foremost, we worked with our leadership team to identify our goals. We then have the privilege, we work with 37 primary care practices, so we narrowed that down to 5 primary care practices that we would like to identify as our spokes. And we intentionally chose them as people that might be a little more eager to learn technology and maybe have some complicated substance use cases. So we did a needs assessment of those 5 practices to help understand if they're really interested in doing Project Echo, and if so, how would this work well for them in terms of their operations and their day-to-day workflow? So for us, that looked like doing Echo clinics twice a month for 1 hour during Wednesday lunchtime blocks. Other Echo clinics function much differently. For example, in New Mexico, they run their substance use clinic every week for 2 hours. So again, for every location, it looks very differently. The next thing we did was we created mini implementation teams. And I think upon reflection, this was probably one of the most critical pieces to the success of our pilot. So this looked like nurses, social workers, behavioral health staff that are embedded in those 5 primary care practices that can really support the PCPs in identifying cases, helping them troubleshoot when they were presenting, and just really help with the nuts and bolts of the Project Echo that we were hoping to pilot. And then lastly, we really talked a lot about the importance of having a good facilitator on that core hub. So I'm sure all of you have been on conference calls that have gone completely haywire when someone's monopolizing or there's no direction. The same holds true for any kind of virtual conference. So we really were looking for someone who had a strong ability for time management, someone who could have clinical background to synthesize the cases that have come through, and as we've coined, a virtual crowd control person that could help out. So just as important as the operations for our implementation stage, we did a lot of work around technology. So our Echo has a 60 minutes that we have to present a case, and then we do a 20-minute didactic. So that didactic is typically curriculum that's based on the topic that you're wanting to share information about. So we created curriculum specific for substance use disorders, and we tried hard to match it with the cases that were coming through. So for example, we had a case on Wednesday where the patient had an issue with benzos, and one of the addiction psychiatrists who sits on our hub provided a 20-minute didactic about best practice for all of the participants. The cool thing with Project Echo, also part of their education and commitment to sharing, is they have a library that I parallel to Google that you could type in, search for the topic that you're teaching on, and you can find didactics, you can find a whole slew of information that's really helpful. Again, for the technology piece, we found our mini implementation teams to be really instrumental. They brought their laptops in many instances to the primary care practices. They downloaded the application that we use to have the virtual conferences every other week. And they troubleshooted with all of the technology issues that always undoubtedly arise. So sound issues, cameras going off. So that was, again, really, really helpful for us. And so what does this actually look like in application? So as I outlined, each Echo clinic happens twice a month at Newton Wellesley. We have about 15 minutes for the PCP to present their case. The next 15 minutes is spent with that multi-directional feedback, with the core team providing recommendations, the spokes also providing impressions and recommendations. The next 20 minutes includes a learning didactic, where a hub team member who is a content expert talks about whatever that curriculum topic is for the day. And then if we get there, we have 5 or 10 minutes. It's mostly like 1 or 2 minutes for closing questions and comments. It's important to point out that we do a bit of pre-work. So probably about a week before the Echo clinic, we have an administrative team that reaches out to solicit cases from the primary care providers. A big important point that we make is that all protected healthcare information is removed from each case before it's presented. So they go through, they comb through the cases, and they prepare that case to be presented at the echo clinic. And then there is a bit of post work that takes place. So an administrative team member listens to the echo clinic. They write down all of the recommendations that have been suggested during that time, that hour period, and they email it back out to the team, and specifically to the provider that was presenting their complicated case. So this is really helpful. So when the provider sees the patient in the future, they can reference this document, and they can even put it right in their Epic note if they want to. So I'm going to pass it over to Jennie to talk a little bit more about our implementation phase.
Thank you. So I think Alanna already mentioned one of the things that we really felt was key was that we identified practices where we felt we were going to be successful. And those practices are practices that are engaged in our patient-centered medical homework, so they're already kind of primed for team-based care. They tend to be multi-provider practices. They have NPs, RNs, MDs, and MAs. So we picked the best of the best, the ones we thought would be early adopters. And then when you're thinking about the hub, if you're us in a community practice setting, here's what we don't have. We don't have an addiction psychiatrist. We don't have an addiction psychologist. We really don't have a pharmacist who's available on an outpatient basis to help us with issues around substance use disorder. And we don't have an outpatient behavioral health department in our hospital. So really, we have a great need, which is why I think we were a great place to pilot. So the hub was comprised of that clinical expertise, and the spokes are our multi-group practices. And now I'm going to ask you all to be nurse clinicians, and I'm go through our very first case, okay? So our first case was actually brought by a very brave PCP. She had a lot of anxiety about being in front of the camera. This is something that we see fairly frequently in primary care. A 53-year-old gentleman who has hypertension and diabetes. His liver functions are normal. He's going through a separation, and he's a father of 2 young children. He's in a high-stress job. He's an attorney in a law firm, and there's a fast pace to that. Being a case manager, I always want to know what your insurance is, so he has great insurance. However, he does have a high deductible, so he has good commercial but high deductible. He's financially secure, but one of the things that really jumped out at me is that he's currently the sole provider. So when you're thinking about life stresses, he's got a lot of stresses going on, right? He's separating, he's got a high-stress job, he's the sole provider, and he has a high deductible. He does use tobacco, and there is some literature that we had just come across. Tobacco and substance use disorder tend to go hand in hand. And then this part I thought was really interesting because it really demonstrates that the PCP had started to ask some of the key questions, right? So she somehow got him to talk a little bit about his relationship with alcohol. He uses it to help him wind down every evening. He says he has at least 2 to 3 beers a night. He was a jock before when he was in high school. He was very active with his social group in college. He goes out with the guys every Friday and Saturday night, and has between 8 and 10 rum and cokes. And he doesn't see his relationship with alcohol as an issue at all. And I think one of the things that's really interesting is this is not abnormal in primary care. That the physician or the provider may see that there's a worry, but the patient actually, this is how he's operated all of his life. He doesn't see it as a problem. So one of the things that we've gotten very good at in our work with behavioral health, thanks mostly to Alanna and her team, is a phrase that I coined, what's the ask? So before we go through any group of experts, we usually ask, what is it that you're worried about? How can we be helpful? And it seems like a really simple question, but I think you get a lot of bang for your buck. So here were the questions that our PCP was worried about. 1, should she be worried? She's worried. He's not worried. So who should be worried? Does he have a substance use issue? If he does, and he's already feeling there's not an issue, and I probed him a little bit, but he really doesn't want to go any further than that, How can I broach this topic with him without him becoming defensive and becoming alienated? One of the things we see frequently in primary care is primary care clinicians who have relationships with their patients worry about somehow losing that connection, and they really have to think about the decisions that they make. And then what should I do next? So here's the hub's input. One, and I was really impressed, they validated for the PCP all of the great work that she'd already done. She'd really worked hard on this one, and she was very invested in the patient. And their response was, well, this is great because Mark keeps coming back, so he obviously trusts you, have a trusting relationship with him. We should consider using some standard assessment tools. I think one of the things we heard about today was perhaps a lack of objective data collection and some subjective stuff, but not always objective. Ask Mark open-ended questions and listen for change talk. And for anybody that wants to know more about motivational interviewing, we'll be happy to provide that for you. But my understanding of change talk is pieces of a conversation where you get a hint of ambivalence or a desire to change, and really focus and draw out on that. Consider other things that Mark could do to reduce his stressors. And then in terms of medication management, consider giving a drug called naltrexone for him to take with him when he goes out with the guys, because it will reduce his craving. So he will still drink, but he may not drink 8 to 10 beers or rum and cokes a night. So then we debriefed with both sides. The hub, Alanna's on the hub, I'm on the spokes. So what were the surprises or the bidirectional outcomes? The PCP felt immensely relieved because she'd been validated in her work. She thought the hub's suggestions were helpful, but she was a little bit uncomfortable with the medication recommendation. It's not something she'd ever heard of, and she really felt like if she's gonna try it, she'd want to dock into somebody that could talk her through it a little bit more. And interestingly, I was a skeptic. I thought the folks in the audience would not be interested in the didactic, that they'd only want to hear the case presentation. But in fact, they found the didactic and very helpful. And then the hub was really surprised because they're all experts. And they couldn't believe that actually these were the kind of questions that were being asked. They were thinking that the questions were going to be much more sophisticated. But in fact, this is where our PCPs are at. So they were surprised and they saw additional educational opportunities. They were really psyched that motivational interviewing was well received. And I think an awareness by leadership that we need to have more education. You just can't tell somebody, well, you could try this drug. You really may need to walk them through that. Am I midpoint or you? I'm midpoint, okay. So our pilot goes from January to June. We're hoping to continue it, so we're at our midpoint. We wanted to expand our spokes because part of what Alanna has mentioned is that, you know, as many people in your community as you can bring in that are relevant, the more information you can share and the more sense of community you can create. So we've started populating, and you'll see we've gotten folks from the Newton Wellesley Pain and Palliative Service to attend. We've gotten the ED, case manager, and social worker to attend, and we've even had somebody from inpatient care case management come. So the other thing that was surprising and gratifying to us that Brent Forrester, who's the head of behavioral health for population health management and works at McLean, has started sitting in. And we do find a lot of elders who have substance use disorder in the Medicare population. Because you're all data people, we asked partners for some data. Now this is survey data, so it's not crisp, it's not hard, but you know what was exciting to me to see how many PCPs, physician assistants, nurse practitioners are actually listening to these conversations. So it's 3 practices, so that's not a bad number. I would expect social workers, care managers to attend, but I'm really happy to see that our other disciplines are hanging in there. So in this one, what do you like about ECHO? Not surprisingly, they really like the case-based learning, but not too many of them, if you're looking at that lowest number, are yet feeling comfortable with what they should be doing for a patient with substance use disorders. They need to know more. So I almost see this particular survey question as an inversely important variable. And then the last one, because of echo I have, so what have you gained from it? And many of these questions are similar, but it looks as if overwhelmingly they feel that they have more tools to help them work with patients with substance use disorder. I'm going to turn it back to Alanna.
Great, so we wanted to talk a little bit about the pros and cons of Project Echo, and I think a lot of the barriers, as I mentioned earlier, are certainly the technology pieces that can come up. We've had anything from weird sounds happening, cameras not working. In other echo clinics that I've observed, since you're on video, people have been flossing their teeth. A whole slew of things can happen. It also takes place during lunchtime, so a lot of time people are eating and they forget that everyone can see what they're doing. So that's certainly a barrier, but again, those mini implementation teams are critical for helping us work through those little glitches that come up. There's certainly a cost that comes with Project Echo. For us, we've seen this as relatively low cost because many of our staff already have laptops. The software is really low cost that you need for the actual application to have your echo clinics. And then to Jennie's point, a lot of our PCPs are really uncomfortable about going in front of a video, presenting a case. I think there's some vulnerability around that. So again, our little implementation teams were supportive of that and either sat with a PCP or our last echo clinic we had this week, we had a whole team. So we had a PCP, a social worker, a nurse care manager, and an in-home PT therapist that sat together and they presented the case as a group. So I think I'm obviously biased, but I think the barriers are certainly a lot lower compared to the benefits that come out of Project Echo. So in the same vein, as I mentioned, it is primarily low cost. You have to pay for the tech, you have to pay for your hub experts, but other than that, it's pretty cheap. And then the ability to spread knowledge is exponential. So we've been able to touch already so many providers really quickly, and we anticipate that to just grow and grow as we'll show in a minute, and to build off the slide Jennie just showed. The other piece that we didn't mention is every echo clinic provides CEUs or CMEs to any of the participants. So doctors or nurses or social workers that come get credit for that. So it's a little bit of a carrot for them. And it really promotes professional development that isn't offered at such high frequency of a 2 times per month basis for most employees. And then I think overall the core tenets of ECHO is to promote improved healthcare delivery and improve patient outcomes. So we're seeing that certainly at Newton Wellesley, and you can read a lot about other iterations of ECHO that exist out there now that show the same great outcomes. So our future vision, and we admit that this is quite advantageous, but we'd really like to target the community, encourage other people outside of the Newton Wellesley space to come in and listen to ECHO, provide feedback to our team, and specifically looking at smaller organizations. So at Newton Wellesley, we don't have an outpatient behavioral health or substance use clinic that we can directly refer to. So we would like to partner with some of our community agencies and invite them in, because we're confident that we share similar clients. Also, for anyone who's had to get authorization for any of their clients, it'd be great to have an insurance company on the line talking about maybe what barriers they see from their perspective, and having a space for us to also talk through what challenges we're having with our patients. And then also for Newton Wellesley right now, there's a big initiative within the City of Newton, City of Wellesley, and Waltham with their task forces. So that's another opportunity where it would be great to engage with the community. Some ECHOs that exist currently have upwards of 30 to 40 spokes. So although this is a bit aggressive, we do think that could be a great goal in the year to come. And then finally today, I think we'd like to leave you guys with other organizations that are also doing ECHO clinics at their sites. So as you can see, this hits on a lot of other healthcare needs, and you can actually contact the New Mexico Project ECHO clinic and ask for information. And even if you're interested in any of these ECHO clinics at other organizations, they really promote sharing and learning. So it would be completely appropriate to send an email and ask for more information. So I think that's all we've got today. So people...
So we definitely have time for questions. Are there any comments, thoughts? I know, it's rough.
I know it's hard. I like talking, so.
Please.
As you can tell, I've been up here all day, right? So I have a couple, actually. So where do the experts come from? Are they within partners? You had mentioned a low cost being, there's a cost for the experts. So where are you finding the experts to be the didactic and all that kind of stuff?
Sure, great question. So we have found our experts within the partner system. So we have a psychiatrist from the Brigham, we have an internal PCP who has an expertise in substance use from MGH. We have a pharmacist, I think she's also from the Brigham. I sit on there for the social work representation. So we really have kept it internal to Newton Wellesley.
Right. So that, in a sense, they get permission to do this and spend some time on it. But if you say you want to expand this to community health and that kind of stuff, where do they tap into you and leverage your experts? Or if let's say you're a small hospital somewhere and you want to start this, is there a way within the ECHO methodology to reach out to experts in other states? Or do they help you find these people so that you within your organization can start this process? You don't have an expert, but you need help with this particular kind of thing. How do you start it without those, like a big partners organization?
Yeah, great question. So I think first and foremost, the goal to include the community is part of that commitment to education. So we had Riverside Community Advocates. These are all really small nonprofit organizations.
Right.
They would just join our hub as part of our commitment to work on the substance use epidemic within the community. If it was another hospital that was really looking to create their own hub, probably, and I'm not sure what your thoughts are, Jennie, but it seems like working with the Project ECHO organizers and the people who really started this model makes the most sense, because they can help with funding, they can help with figuring out how to find your hub experts. There's a lot of work going on right now in legislation to make this so it's something that people can bill for. So there might be more motivation for smaller hospitals to find the funding.
Not necessarily of hospitals, but I'm thinking of large group practices,
yeah.
Right? And so they have a mixture of MDs, NPs, a mixture of providers. They are definitely going to have patients that they don't know what to do with. They're uncomfortable. They don't know what the next step is.
Yeah.
They meet together and talk, but they can't. They would love to reach out and see what it is. But it appears like an expense because it takes time away from their revenue source. And where do they find those experts and set something up like this? So in this kind of large group practice setting that may not be affiliated with a hospital that has a bunch of experts available, is that a model that exists within this ECHO environment?
I think that it would probably work with that connecting with a bigger group that already has an established ECHO clinic, and then seeing the functionality. Did this work for us? Are we strong enough and big enough to have our own? Or perhaps it stays that they're already just joining an existing ECHO clinic.
I think the other thing is that Alanna alluded to the library, which is the box.
Right.
So once you get access to those, all those are already built CME, CEUs. So that isn't something that you would need to necessarily replicate. I think it's an interesting question. I would hope, I could just imagine that most medical groups are affiliated with somebody, so it could be that a hospital that you're affiliated with may have that. So we know UMass does, because we looked them up. Boston Medical does, BI does, Partners does. So I think you might be able to find some like-minded people. And when we did reach out to the BI, I think it was the BI, they were like, yeah, come and sit on in, because there's no patient information given, and people, Alanna described the New Mexico people as being sort of missionary, and they're missionaries. They really want to promote this technology, so they're very welcoming. I would think they would be very helpful in just calling and saying, hey, I want to try this thing, how do I do it?
Yeah, in fact, just quickly, they have supported us throughout the whole pilot, and they have walked us through every single step, and I'd imagine they would do that for any type of organization, whether it be very large or quite small. Yeah.
I think, too, the 21st Century Cures Bill just passed, and I think there's quite a bit of grant funding associated for behavioral health and substance abuse. So I have a feeling that as smaller providers start to say, you know, I have a need and I don't know what to do with it, my sense is there's going to be more collaboration and requests for grant funding and figuring out, you know, kind of how some of this works. I would say the other is in terms of the payer relationships. They're really concerned about comorbid and total cost of care associated with those diseases. And I would think there could be a way, too, to tap into not the experts, but that the payer would have the expert, but the payers could maybe fund some of it for the smaller groups, I think.
Great point.
Hi, my name is Susan Katzlowski. I had a question about the organization of the actual clinical presentation. You mentioned that the PCP or the provider presents the case first, and then there's sort of a round-robin response, and then the expert sort of chimes in for 20 minutes at the end. To me, that almost seemed like backwards, and I was wondering why your expert with best practice would be at the caboose and not at the forefront. And so I was just wondering why that structure emerged and the success of that. If you want to comment on that. Yeah.
So you're asking why the hub experts provide their recommendations last, is that right? So I think there's probably a varied response to that, but my impression is that it's to empower the hubs to provide suggestions and impressions, because we've found that they have a lot of valuable clinical information as well. And then it's kind of as like capping up the whole conversation at the end to summarize the case, provide really straightforward clinical recommendations, and then move on into the didactic learning session. Is that helpful?
Yes, thank you. I was just wondering. You could see where my
Yeah.
mind was coming from.
Yeah.
And I think the other thing is they usually have, after they've done the didactic, they usually regroup, ask if folks have questions or want to share anything. What's interesting to me is if you do it right, which I think we've gotten pretty good at, it's very structured, right? You really have to facilitate it, because otherwise you're not going to be able to have that dialogue, albeit a structured dialogue, between the expert and the clinician in the field.
Thanks.
Great.
So I would just make a pitch. Alanna's done a great job launching this. She came back from New Mexico very jazzed. We would be delighted if anybody is interested in learning more about what's been put together, to just contact us. And, you know, I think we'd be delighted to show you. We made Sandy come and sit in on 2 echoes. Thank you.
Thank you. Oh, thank you.